So good afternoon. It's a real pleasure to welcome you to this ERKNet, ESPN, and ERA EDTA educational webinar. We have a truly exceptional topic and a couple of speakers today that I'm very, very glad to have the privilege to moderate and introduce. The topic of today is lupus nephritis, and the structure of this webinar is going to be slightly different because we're going to have two talks. The first talk is going to cover lupus nephritis in adults, and it's going to be given by Hans-Joachim Anders. And you can then ask questions. And after the end of that talk, we will have a talk on lupus nephritis in children, which will be given by Stephen Marks. During both talks, you will have surveys that you can interactively participate in, and that can be useful learning tools. So I'm very glad to be able to introduce, without any further ado, Professor Anders. Professor Anders is truly an outstanding expert in lupus nephritis, and he has done a lot of research on the role of innate immunity in kidney injury and repair. He is professor of nephrology at the University of Munich, where he also runs the Lupus Nephritis Clinic. He is also an associate editor of NDT and JASON. It is truly a huge honor and pleasure to introduce him, and we are very, very eager to hear what he can teach us today on lupus nephritis in adults. Over to you.
Thank you, Marina, for the kind introduction, and thanks for the organizers for inviting me to give this webinar. Ladies and gentlemen, I'm always pleased to speak about lupus nephritis, and let's see what we can learn today. These are my disclosures. And this is the outline of the presentation. So we'll start out with a little bit of pathogenesis because I think it's important for patient education. Then we will talk about diagnosis and treatment goals and the treatment of the first episode and how to assess the treatment response. And I will close with some words about long-term management. Okay, so the pathogenesis. Here we can have the first question. So I hope this can work. I can read it for you. Which statement on the pathogenesis of lupus is correct? The pathogenesis is still unknown. It's a monogenic disease. It's a polygenic disease. It's an environmentally triggered disease, or it's a multifactorial syndrome. So how we move on from here? I don't think I can see the results. So I don't know, maybe Marina, if you want to read them.
Yeah, so I'll read the results for you. So Joachim, 78% of the public responded SLE is a multifactorial syndrome, so the last reply. 18% replied the pathogenesis of SLE is still unknown, and 2% SLE is a polygenic disease, 2% SLE is an environmentally triggered disease, and nobody chose SLE is a monogenic disease. So the vast majority went for multifactorial.
Okay, so this is a very interesting survey. There is no true answer here on this, but I will give you some explanations and maybe you will change ideas a little bit on your own votes. So the pathogenesis is for sure complicated. This we can is still true, but I think the only wrong answer in all the options was that the pathogenesis is not known. I think we have learned a lot about the pathogenesis of lupus, and it all starts from the handling of nuclear material. So lupus patients are normal people, but they have one problem. They cannot keep their nuclear material away from the immune system. This is what is usually the case. Nuclear material is usually encapsulated in the cell nuclei, and through a proper cell death of apoptosis, this nuclear material is kept away from the immune system. Apoptotic bodies are phagocytosed by macrophages and neutrophils without the nuclear material entering the extracellular space. And in lupus patients, this, for the one or the other reason, doesn't work properly. So either the mode of cell death is different, so cells undergo necrosis and nuclear material is released in the extracellular space, like for example in net release, neutrophil extracellular trap release, where also chromatin reaches the extracellular compartment, or the apoptotic bodies are not properly opsonized, means they are not marked with eat me signals that would indicate a monocyte to eat it up, or there is a phagocytosis defect. So all these defects are introduced by genetic factors, and each patient probably has a different sort of defect. Yeah, but the result is always the same: that nuclear material remains in the extracellular compartment, and then it's handled like a viral particle. And I don't have to tell you much about viral recognition, because now with this COVID pandemic, we have all become experts on the mechanisms of viral recognition and how it's handled by the adaptive immune system. But this is the thing you have to keep in mind, that extracellular nuclear material looks like a virus, because it's a small piece of nucleic acid together with some proteins, and that basically looks like a virus. And that's why all the symptoms of lupus are kind of a chronic viral disease: muscle pain, joint pain, fevers, skin rashes. It's all driven by the same mechanisms of viral recognition and antiviral responses. So here, this is a slide for those of you that didn't believe that lupus could be a monogenic disorders. There's indeed a broad literature now about monogenic forms of lupus. And these are forms of lupus that originate from severe mutations in the interferon pathway, because interferon is important in antiviral host defense, and lupus patients have a sort of chronic virus-like infection, virus infection-like immune response. So interferons are very important also in lupus. And there are people that have a monogenetic disorder where the spontaneous overactivation of interferons. Then there are people that have complementopathies. So they have deficiencies in complement factors like C4 or C3. So they lack important opsonins that would mark nuclear material for rapid phagocytic clearance by macrophages and neutrophils. There are people that lack DNase or RNases that could chop down extracellular chromatin or RNA, and in this manner they persist to activate the immune system, which then induces all the symptoms of virus infection-like symptoms. And there are people that have defects in proper forms of apoptosis, and this is the autoimmune lymphoproliferative syndrome, because then you end up with many more lymphocytes as other people. And then what happens if the immune system is activated like by a virus? You get an antiviral response triggered by interferon alpha, and then happens what happens after every vaccination, and also on this we are now all experts. You get an antigen presentation and activation of antigen-specific B and T cells, and here are a lot of cytokines and immune cell types involved. And it's not a single factor; these are many factors that we need to mount proper antiviral immune responses. And the same happens in lupus patients because they vaccinated themselves against their own nuclear material. Okay, and here you see all the genes that can be involved in this in humans and in mice. And this is complex, and this means every patient has its own combination of risk factors that gives him this disease. So genetic disorders we can understand like an iceberg, where at the tip of the icebergs are these classical syndromes that have been defined in the old textbooks, these monogenic forms where a person has a one severe variant, and this already gives a phenotype. But for each of these patients, you have hundreds of others that have not so bad genetic variants that by themselves don't give a disease. Okay, these are more the silent bystanders. And lupus, as we have so many different ways into lupus, you have sort of many icebergs. Yeah, on the complement genes, the interferon genes, the lymphoproliferative genes, the nucleases, and others. Each of them can give lupus, And the broad spectrum of patient comes from the fact that here now exist completely different combinations of predominant factors and cofactors, bystander factors, and all these people share only one thing, is that they have antinuclear antibodies, okay? And antinuclear antibodies is the proof that there was a loss of tolerance, so the people have auto-vaccinated themselves against nuclear material, but the ways to reach that can be extremely different. And that's why we will probably never have a drug that will help all lupus patients the same way, because the pathogenesis of these patients can be quite different. So they are heterogeneous. So, and this one can represent maybe like an archipelago, and I put the same topics here, but for lupus nephritis, you will certainly have patients that have a genetic GBM weakness. So maybe a collagen variant that makes their GBM a bit thinner, and these people will have much faster hematuria, right? Get an earlier diagnosis of a kidney disease probably because you do a biopsy much earlier. You have others that have endothelial weakness through genetic factors, or podocyte weaknesses, or poor nephron endowment at birth and have hyperfiltrating nephrons, which then get much earlier into trouble with proteinuria, for example, than other people that have many nephrons. So that means the diversity here is enormous, and this is what we have to understand when we want to address single patients that are maybe different from other patients, and to understand why certain drugs help some people but not others, okay? Because lupus is not a single disease, it's a diverse syndrome. Okay, just one example here, a patient that taught us a lot about this, girl with lupus nephritis. You see here the first manifestation was a nephrotic syndrome where she received steroids. The biopsy was done class 2, and after she went into full remission, interestingly, the pediatricians did a second biopsy, and that second biopsy showed an FSGS lesion, which was considered to be a secondary FSGS due to her lupus, which was a wrong conclusion, but at that time it was thought this manner. Then the girl took the drugs for some years, then stopped taking them, got a relapse, third biopsy done, lupus nephritis class 5, and then again immunosuppressive therapy, and from there she didn't went into full remission anymore. She didn't go in full remission anymore, and the immunosuppressive therapy was escalated more and more. But meanwhile, the creatinine started to increase, and when she turned 18, she came to me, and I reduced all this immunosuppression that she had never seen a patient on 6 different drugs of immunosuppression. And then anyway, she had a relapse. I mean, she didn't come down with the proteinuria as we wanted. So we did another biopsy, found class 6, and 1 year later, she was on dialysis. So this was something I'd never seen before. I found quite strange. So we went to genetics, and then we found that she had a podocytopathy. She was a homozygous case of a nephrin mutation inherited by both patients with an issue of consanguinity here also. And she had also the APOL1 risk alleles because she was from West Africa, from Senegal. So, I mean, this girl basically had 3 problems. She had a hereditary podocytopathy that could give her FSGS and nephrotic syndrome even without a lupus. But this variant was not so bad. On its own, it didn't do a nephrotic syndrome. But then she had APOL1 as an accelerator CKD gene, and she had also the lupus. But the lupus was not her problem, the main problem. That's not why she ended on dialysis, but that what kicked off the whole problem of the primary podocytopathy. So I'm pretty sure we will have many patients like this if we only start to diagnose them a bit better and to put into question this concept of the refractory lupus nephritis, because it's like with idiopathic nephrotic syndrome. If a patient does not respond to immunosuppressive therapy, there's something wrong. Lupus is a disease that should always respond to immunosuppressive therapy, and if it doesn't, there is a problem. The patient don't take the pills, or there's some other genetic problem or some other problem. But a lupus is usually susceptible to immunosuppressive therapy, like, let's say, steroid-sensitive nephrotic syndrome. So this is what I want you to take from here, that if a patient doesn't respond to immunosuppressive therapy, there's something wrong, and we need a second round of diagnostic to find out. Okay, so let's speak about diagnosis. The diagnosis of lupus is set in new classification criteria from the EULA ACR. These are not diagnostic criteria. We know this discussion, but the classification criteria are anyway quite useful. And there are two things that I want you to take from there. First of all, there is no lupus without antinuclear antibodies. Yeah? Sometimes we have this question, I have a full house pattern in the kidney biopsy, but patient has no antinuclear antibodies. This is not a lupus, okay? There is no lupus without antinuclear antibodies. That's the only thing lupus patients have all in common. The second thing I want you to take from there is that to make the diagnosis of lupus, you don't have to have all these things at the same time. Yeah, they can happen one after the other. And it's therefore very important also for nephrologists to take a careful history. But there's a third thing. If you look into the renal domain, if you get a kidney biopsy of a proliferative lupus nephritis, you already reach the number of points needed to make a diagnosis. So it means antinuclear antibodies plus proliferative lupus nephritis makes the diagnosis of an SLE. Good. Now what we do with the kidney biopsy. I have seen the slides of Stephen that he will guide you through the different classes. But this is almost a medical history, I have to say, because we have this classification since 40 years, at least 50 years. So everyone knows this. I want to alert you to something else. How we do the diagnosis. We need an alarm system. So this is here my fire alarm, and this is the urinary dipstick. So a lupus patient with a normal dipstick, no problem with the kidney. But if the dipstick shows proteinuria and hematuria, is likely to be a glomerulonephritis, and we need the biopsy. And what we try to do with the biopsy, it's not that we try to find class 2, 3, 4, or 5. These are historical categories that we are repeating all the time, we're using all the time, but what we are really interested in, because these are not set by God, you know, these were inventions. So what do they really tell us? First of all, we want not to miss a disease that has a poor prognosis, so that we miss the chance to treat early. And the second thing is we want to know how much of the kidney is affected and how active is the process. And for this, I try to explain kidney biopsy in this manner. So when the activity is low, and the activity is not written in the classes, the activity is written in the activity index. And this is something you need to ask your pathologist. So if the activity is low, probably the patient doesn't need immunosuppressive therapy for the lupus. This is class 1, class 2, and at least in my center, we also don't treat class 3 if the activity index is low with immunosuppressive therapy. We may give some steroids, but don't give cyclophosphamide or anything. And there may be a podocytopathy. This is global, but this you will treat like a minimal change disease or will be a steroid-sensitive nephrotic syndrome. So that you do not need necessarily immunosuppressive drugs to treat a podocytopathy. But this you decide based on the activity index. Then if the activity index is high, we need immunosuppressive treatment no matter what the pattern is. Yeah? And the class 3 is a focal, and class 4 and 5 is a global lesion. But here the immunosuppressive therapy is needed for the high activity, the immunological activity. And this is what the biopsy is about. So means activity in the end is a bit more important than what the distribution of the immune complexes is, whether they are under the endothelial cells or under the podocytes. I mean, this is not what makes me decide for the treatment, but the activity is the critical part. So what are the complications of kidney biopsy? There's a big meta-analysis just published in CJSON, I think it is. And here it tells you that when you advise the patient for the biopsy, what you have to tell them. So hematoma is frequent, and I need to move this a bit. Hematoma is frequent. Back pain can be there for a while. Macroscopic hematuria is always a worrisome symptom for patients, but the death rates are low. So I think this is something we can tell patient pretty well. This means kidney biopsy for everyone, and this includes also the 80-year-old cardiovascular patient. So what is more important for the young female is the complication rate in lupus patients, and there is a publication on this. And there is a paper from 2012 from the Hong Kong group that shows that any complication of the kidney biopsy is around 8% in lupus patients. So it's not so low actually. But the particular risk for the severe complications, so major bleeding, is pretty low, 2%, but it mostly refers to the patients with the low platelet counts. So if you stratify the patients for kidney biopsy and avoid to do it with low platelet counts, then you can probably avoid these severe complications. Good. Let's speak about treatment goals and patient education. And here is my next question. Who should best treat a patient with lupus nephritis? And you can see the options. Okay, maybe this is a quick question.
Yes, so I'll read you the replies. So 53% went for a nephrologist, 41% for all of the above, only 4% a rheumatologist, 1% an internist, and nobody answered a primary care physician.
Yeah. Okay, thank you. This is very interesting. Maybe I should have specified a bit better in which phase of lupus nephritis, because lupus nephritis in the acute phase, when you do the diagnosis, the patient will almost always be in the hand of a nephrologist. This is good, although I know a couple of talented rheumatologists that know everything I know about it and even more. So I would be happy to be in the hand of such a rheumatologist to treat my lupus nephritis without problems. So, but every patient with lupus nephritis has lesions more than 3 months. And this means he is a CKD patient or she is a CKD patient. If you are once a lupus nephritis patient, you will always be a lupus nephritis patient. That means this is not something the nephrologist can do for the rest of the life of the patient. So what is needed is that in the beginning, the nephrologist makes the diagnosis, then discusses it with the rheumatologist, and then decides on the treatment plan, and then may do some follow-up maybe in the first year, the second year, but on the long run, you need all of the others to take care of this patient. And that's why in my clinic, I have a lot of very engaged primary care physicians that are happy to send me the patient from time to time, and then I advise them how to go on, and then I don't see the patient for another 2 or 3 years maybe. And this is okay. So for some patients, this works extremely well, and others, it's different, and there I need to see the patient every 2 or 3 weeks, yeah? But for the most of the patient, I think they can be handled very well in the later phase by the primary care physician, and it's only important that we talk to each other. So then the treatment goals, I want to show this slide because people, when they read the studies, they think the treatment goal is to have a proteinuria of 700 after 1 year or so, and then I have reached my goal. This is not true. The treatment goal of my patient is that they want to become 90 years of age, like all of us, and they don't want to end on dialysis. And they don't want to end on dialysis in 5 years, not in 10 years, not in 15 years, but they don't even want to end on dialysis by age 80, and then to go on dialyzing another 10 years up to when they die, okay? So that means our treatment goal is that a patient with lupus nephritis will never, ever end on dialysis. And this is not easy because you know that the normal kidneys have a lifespan of around 120 years maybe, so that's why most of the population doesn't end on dialysis. But if you have an AKI, and acute lupus nephritis is a sort of AKI, you may lose a significant number of nephrons. And I would say that in a severe episode of acute lupus nephritis, patients lose about 20 to 30% of their nephrons. And this means around 30, 40 years of kidney lifespan. And that makes it pretty likely that a patient with the first lupus nephritis episode will end up on dialysis later in life. And if you don't do a good job, and this patient will ever experience a second episode of his lupus nephritis, this may mean to lose another 20, 30 years of kidney lifespan. And the patient will end up on dialysis then by age 50 and not by age 80. So this is a disaster. That's why the treatment goal is that a patient with lupus nephritis never, ever experiences a second episode, okay? And this is very ambitious, as you all know, but this should be our treatment goal. That's why we have to do a lot of things to avoid that. Okay, and how we do that? I mean, the first goal, if you deal with patients, always to limit mortality. And in lupus patients, they die from infections, they die from cardiovascular disease, and from high blood pressure. And we have to address all of these things. Yeah, so all of our patients have CKD. This is important. They have the CKD-associated immunodeficiency. So that means vaccination is absolutely important, and infection control. And as we know that CKD is the worst known cardiovascular risk factor, we have to be very cautious for their lipids, for their blood pressure, for all of these things, even if it's a 20-year-old female. And the second mission is to prevent end-stage kidney disease, because this would severely impact their quality of life. And on that, we have to avoid the second episode, as I said, and any further nephron loss due to medication, NSAIDs, or painkillers, other things that could lead to further nephron loss, because this patient has already lost too many nephrons, will already put his kidney lifespan in danger. Then pregnancy is a major treatment goal, because we are dealing mostly with young females that more or less all want a healthy pregnancy. And healthy pregnancy is already a challenge for healthy kidneys. So imagine two people that lost already 20, 30% of their nephrons. So that will always end in severe hyperfiltration and puts the fetus and the mom at risk. So that's why careful counseling is very important. And then we need to inform the patient about the pathogenesis. This involves questions of genetics, guilt, transmissibility of the disease, to avoid alternative medicine that could be harmful, to educate them that they can live a normal life or should live a normal life with lupus, advise about family planning, the vaccines. Now COVID is a big issue. Drug adherence is a major concern in treating these patients, sun exposure, travels to tropical countries, and so on. So, I mean, there is a lot to speak about, and you need first visit at least 1 hour. I always book for the patient because there's a lot to speak about. And I usually give a new patient a book to read about lupus, because I need my patients to be lupus experts, because they usually deal with doctors that don't know nothing about lupus, and this is a big danger for them. And the patient has to learn not to trust any doctor anymore. I mean, every doctor anymore, when it comes to the lupus, the patient needs to know much more than most of the doctors about lupus. This is the only way to protect them for unhealthy medicine for them. Okay, the treatment of the first episode, I want to make brief, because I think Mark will speak about that, as Stephen will speak about that. Only a few points. Antimalarials are essential for people with lupus nephritis, because they are drugs that have shown to improve mortality and flare rates, and that's why there is great evidence for antimalarials. Yeah, there are other fundamental things to talk about. To minimize sodium intake is the best way to reduce proteinuria. Yeah, if you don't manage with your ACE inhibitors, don't increase the steroids or immunosuppressive drugs. First, minimize sodium intake. In most of our European countries, sodium intake is crazy, and people need to be advised. It's the best way to reduce proteinuria. Oral contraception is no problem with lupus nephritis, only with antiphospholipid antibodies. I prefer the mini pill in the second method. I advise all my patients to use a drug app on their mobile phone to remind them about taking the pills, just to not to start to cheat yourself. And I can read these results. They can send me the PDF of what they did, and even recording the blood pressure in this manner is very useful. Then the story of the vaccines, you know now, we are all experts now on this, no live vaccines for patients with immunosuppression, but the new adenovirus vaccines for COVID, no problem, because there are no live vaccines. Then cardiovascular risk factor control, obesity as an obesity control as an anti-proteinuric therapy, sun protection, and then vitamin D for everyone, but calcium only for those that are lacto-vegan, yeah? Because with the dairy products you have enough calcium usually for the osteoporosis. Okay, so the induction therapy, if you still want to call it this way, we have the traditional ones. They will come in the KDIGO guidelines. This is what you know. There are variants that are more attractive in other parts of the world, like the multi-targeted therapy is popular in China. The oral cyclophosphamide is popular in parts of the world where the other drugs are too costly. But in Europe, I think we mostly go with the low-dose cyclophosphamide or the MMF treatment, and then you can switch to MMF or azathioprine. But the new avenue now are the upcoming drugs. You have heard about the 3 trials, the Lupus Erk Nl Te trial. Lupus nephritis is now also within the label for belimumab as an add-on therapy. Voclosporin will come this year, and obinutuzumab as the beta rituximab is on the horizon. And I don't want to discuss these drugs in detail. I only want to say that they introduce a new concept, no more induction and maintenance therapy, because these are continued combination therapies. And I think we will finally start to treat lupus like we treat a kidney transplantation. Yeah? There we also don't do induction and maintenance. There is a continued combination therapy from the beginning to the end. We reduce a bit the dose with time, and this is the same way how we should treat autoimmunity. Alloimmunity and autoimmunity work the same way. There's no reason to do it any different. There are only historical reasons why we started with that induction therapy thing, because you could not go on with cyclophosphamide forever. That was a good reason, but this, what is now engraved in our brains, that story with the induction and maintenance, this is something we have to bypass, because it's not the best way how to treat the patients. And I think these years now we will learn how to use the new drugs as a continued combination therapy. The Chinese, by the way, doing this since a couple of years, and they have great results, and now we have also some European data. Okay, I think I have to go a bit faster just about the rebiopsy question. There are a couple of other disorders that can coexist in patients with lupus nephritis. I mentioned nephrin mutations, genetic factors, APOL1 as a risk gene, but we also had on rebiopsy C3 glomerulopathy, TMA, or even an incident ANCA vasculitis. So do rebiopsy if the patients don't respond well. Do the same like in steroid resistant nephrotic syndrome. If a patient doesn't respond to immunosuppressive therapy, it needs another biopsy or needs other diagnostic, genetics, a second round of diagnostics simply to figure out what's wrong, because usually lupus nephritis responds to therapy. Another interesting point is the hydroxychloroquine-induced podocytopathy, here shown in an electron microscopy of the podocytes. So this can be a sequelae of long-term chloroquine treatment, but there have been even now patients reported that had a concomitant Fabry syndrome that manifested together with the lupus. So this is probably rare, but simply tells you that the world is colorful, and not all lupus nephritis patients are the same. So I will skip this because I run a bit out of time. I will come to the long-term management. And here we have another question. So what do you think, for how many years immunosuppressants are needed after the first episode of lupus nephritis?
Yeah, so the majority responded lifelong, 41%. Then we have 3 years, 29%. then 5 years, 13%. Depends if you and patient are more afraid of the SLE or of drugs, 10%, and only 7% replied 1 year.
Yeah, okay, this is very good. I can tell you that throughout my training and my career as a lupus nephritis doctor, I can say I went through all these options, also maybe depending from single cases that you see. But I think there is something that we learn also from other glomerular diseases, namely ANCA vasculitis. Whenever you stop the treatment, you run the risk to get back the disease. A certain percentage of patients will come back with a flare. So that means 1 year, 3 years, 5 years, this is something, there may be no evidence on anything else. And this you may take as a reason to decide to do it that way, but it's probably not what someone that works on pathophysiology of kidney disease would recommend. Because if you know that the disease is maintained by long-lived plasma cells in the bone marrow that will stay there all your life, or up to when you do a bone marrow transplantation, the disease won't disappear. And if you reduce immunosuppressive drugs, there's always the risk that it's too few, the dose is too few, and then the patient will have a relapse. So lifelong is probably the right answer, but it's not feasible, okay? And after 10 years of nothing, the patients start to ask, but can we stop this sooner or later? Or they will simply don't take the drugs anymore. So I think this is also not feasible. So that's why I ended up with the last option. It really depends on the patient and your own temperament. And I have patients that are very frightened of the drugs, and I have others that are very frightened of the disease. And with those, I take different decisions. But in general, what we always do is we taper very slowly the dose, and I stop the doses only after really coming down to 1 milligram of prednisolone or really a homeopathic dose of MMF or something. I never stop treatment from one day to the other. And maybe one way of doing this is to do the withdrawal biopsy that you see here, to do another biopsy to decide whether you can stop or not. And this is something, maybe I switch to, no, this slide I took out. There is a study now published from Brad Rovin and Alba Mavar from Argentina, where they did rebiopsies every 2 years to see if there is still immunological activity left. And if there was activity left, they kept the people on the drug. And if there was no activity left, they stopped the drug. And with this regimen, they arrived at a very low flare rate, much lower than what has been reported. And probably this is the right way to go, to really, before deciding to stop the treatment, to do a biopsy, and to stop the treatment only when there is no activity left. If there is activity left, the patient is at risk to develop a flare, and then it's better to go on with the treatment. So what most people do as a rebiopsy is the flare biopsy. That is when the patient comes in again with proteinuria, and this is probably the most unuseful rebiopsy you could do, even though it's the most frequent rebiopsy being done, but maybe we can change that. Because there are good data now here from the first biopsy and the second biopsy, and to see what does it change. And there is only around 10% of patients that really moved from class 1, class 2 to a class that would be treated differently, class 3, 4, 5, and this was not even 10%. 11% of the patients had no change at all, and in 79%, it would have not affected treatment. And these are mostly those cases that had already a proliferative lupus nephritis before. And if this patient comes back with another flare, there's no need to do the biopsy because you already know what the biopsy will show, and you can basically decide on that. That means if the patient in the first biopsy had class 1, class 2, and comes with a flare, do a rebiopsy. But if a patient had a 3, 4, or 5 before, no need to do the rebiopsy on the occasion of the flare. I would rather do the rebiopsy when the patient doesn't respond to treatment as expected. That would be a reason. Okay, then the proteinuric flares, we should also think to obesity. Yeah, obese people go into hyperfiltration, and this is something that there's no need to give immunosuppressive drugs for obesity. Yeah, it's the same with IgA nephropathy, and the steroids in obese people is not something that can help the patient, will make the situation worse. Pregnancy needs careful counseling. Here, just a case that we had with a pregnancy with a creatinine of 1.1 and a little bit of proteinuria, 2 grams of proteinuria, and then the pregnancy ended up basically in end-stage kidney disease 2 years later. This is something one can avoid with careful counseling. Yeah. Here I wrote down a lot of things, what to consider in a pregnancy. I think my time is over, so I cannot read all this to you, but if this is still available online, I'm happy to answer questions to this. Pregnancy should be carefully counseled, should be planned way before. You need to first check how does the patient with the proteinuria, when you stop the ACE inhibitor, because ACE inhibitors are usually masking lupus activity because they reduce hyperfiltration and proteinuria. We do a biopsy before a planned pregnancy to see if the kidney is really clean, and then a pregnancy can be allowed. An unplanned pregnancy can end in disaster. Okay, this was the study I wanted to show before. And yeah, this is now my final slide. I'm sorry, I usually speak too much, more than I wanted, but I want to leave Stephen the time that he deserves for his lecture. And you can read on the latest things on lupus nephritis and this disease primer. I think it's even free online now, and I'm happy to take also your questions. Thank you.
Thank you so much. That was very, very interesting and very comprehensive. And we do have some questions, and we do have, I think we can do 2 or 3 questions. So the first question that I received was from Dr. Evgenia Preka, who works in Southampton. And she was wondering, she's a pediatric nephrologist, what you would recommend regarding patients that have on the renal biopsy so-called low activity index, in which you were saying that it is possible to avoid immunosuppressive treatment. So she was saying, since it's quite tricky to perform repeat biopsies, especially in children, what would you suggest as monitoring for these children with very low activity index in order to balance not doing too much, but at the same time not doing too little either?
Yeah, I mean, there are no studies on this, and this is only my personal experience. I had a couple of patients that where I had avoided an intense immunosuppressive treatment with the class 3, where the activity index was 1, 2, 3 or something like this. And I treated them only with steroids, and they went extremely well. Even now I have a 10 or 15 years of follow-up. So I would not see a reason to do that. I mean, I give immunosuppressive drugs for immunological activity and not for distribution patterns of immune complexes, okay? So I think you should rather think, if you have a patient with class 2, for example, that has a nephrotic syndrome, yeah, this is a disease more similar to a minimal change. So this is more likely to be a podocytopathy. This is a patient that has a weak filtration barrier and probably has a genetic reason why a minimal deposition of immune complexes already leads to a broad opening of the filtration barrier. So this is not necessarily something that requires cyclophosphamide or MMF. So it's rather a specific weakness of the podocyte layer, and that requires rather the usual treatment for a minimal change, let's say, or idiopathic nephrotic syndrome. So that's why I would, with the immunosuppressive drugs, I would rather go by activity, and then we can discuss what is low, what is high. I mean, this is a scale that goes from 0 to 24, and I have never seen 24 in a patient, so I would consider everything above a 7 or 8 as high and should be treated with immunosuppressive drugs. But we have seen biopsies class 3 and then an activity index of 3, 4, 5, and there I don't know if I should give a young female cyclophosphamide or even a kid cyclophosphamide for what. Yeah, the proteinuria we can treat in a different manner, and the long-term prognosis to me is unclear. But this is my personal opinion, so I would never criticize a colleague that would do different things, because that's what's written in the guidelines, but it doesn't convince me from a pathophysiological perspective.
Okay, thank you so much. You've received a ton of questions, so I'm just going to very briefly ask you one other question, putting together actually different questions that people have been asking to try to optimize. So people are asking, especially your opinion on patients with SLE in general, especially children. This is slightly provocatory. Do you think all patients with SLE should receive a renal biopsy? And if a patient has been biopsied, has lupus nephritis, and has been treated, when is your indication for rebiopsy? So indication for biopsy and rebiopsy in SLE.
I mean, the indication for the first biopsy is very consistent across the different guidelines. You go by the urinary analysis. If the patient has hematuria and proteinuria, I would do a biopsy, especially when there are acanthocytes and casts or something. I would even do a biopsy in a patient that has little proteinuria but has acanthocyturia and casts, because this tells me that there is a glomerulonephritis. If a patient has only proteinuria and no hematuria, I would wait up to the 500 that is recommended before I do the biopsy. Then for the repeat biopsy, as I said, I would consider patients for repeat biopsy if they do not respond adequately to the immunosuppressive treatment. That means if after 6 months there is not at least a 50% reduction in proteinuria, I would do a rebiopsy, because there's something wrong. I mean, what we had written in the guidelines before, that if you give cyclophosphamide and the patient doesn't respond, then switch to MMF without doing a further round of diagnostic. I think this is not very likely, because it's not that there are the cyclophosphamide responders and the MMF responders, right? I mean, there must be a reason why the patient doesn't respond, and we need to look into this in more detail. So I would not go for the flare biopsy if a patient, let's say after 3 years of good remission, comes back with a proteinuric flare. I would not do the flare biopsy, because it's likely to show the same thing as before if the patient on the first biopsy had a class 3, 4, 5.
Great, thank you so much. So I think I'm going to have to request that all the other questions are actually, you can contact Professor Anders by email. He has kindly accepted to this. So I really, really want to thank Professor Anders for his time. It's been a really, really wonderful talk. And thank you very much for your attention. And I am now pleased to introduce the next speaker, who's going to focus instead on the pediatric aspects of lupus nephritis. And this is Stephen Marks. Steve Marks is Associate Professor and Consultant in Pediatric Nephrology at University College London, and works at Great Ormond Street Hospital for Children. He has really extensive clinical and academic experience in children with systemic lupus erythematosus, and he has been an expert advisor for ERA, EDTA, EULAR, and SHARE recommendations. So it's a true pleasure to welcome Steve, and I'm sure it's going to be a wonderful, wonderful talk. And so without further ado, here's to you, Steve. Thank you so much for participating.
Thank you very much indeed, and good afternoon, and welcome to the second part of this webinar. Can I just check, Marina, that everyone can hear, see me, and the slides look okay before we start?
Yes, it's all good.
Thank you. Well, thank you for that great first talk, lupus nephritis. We have been collaborating, so we are trying to complement each other's talks here. I'm going to focus obviously on lupus nephritis in children. I think it's important to put in perspective, obviously, that many of the patients that we look after are adolescents, but we do see lupus in children as young as 2 years of age, excluding, of course, the neonatal lupus. I have disclosures of research funding and consultancy, but these are institutionally paid. I get no personal gain from either of those ventures. So I've stolen this from the wonderful internet and social media, and I think it summarizes from patients' perspective that with lupus, every day is a test for survival. So what I've changed my talk to do is a bit of a comparison between childhood onset and adult onset disease, a little bit about epidemiology. As Professor Anders said, I'm going to talk a little bit about lupus nephritis and the classification, some of the justification for the management of lupus and lupus nephritis, and try and bring it all together. So the first question is what proportion of children have abnormal renal function on presentation with systemic lupus erythematosus? So what proportion of children and young people have an elevated plasma creatinine when they initially present? Have you got the poll coming up there?
Yes, Steve, it's fine, and I'll be reading you the results when they come through.
That's fine. Just want to check that it's opened up on your screen.
Mm-hmm.
So is it A, 10% of children have abnormal renal function when they present, B, 20%, C, 30%, D, 60%, or E, 90%?
Okay, so we have the replies, and they're pretty evenly distributed. 27% replied 30% of proportion of abnormal children with abnormal renal function. 26% of our listeners replied 20%. 23% replied 60%. 20% replied 10%, and only 4% replied 90%. So it's pretty evenly distributed towards the central values that you gave, Steve.
Thank you, Marina. So yes, so the correct answer is actually D, which I think was 23% of you. So if you look totally in the adult population, overt kidney disease is present at the time of diagnosis in between 40 and 60%. The highest percentage I could find was our national cohort study in the United Kingdom, which is the United Kingdom Juvenile SLE cohort, where we actually had up to 80%. But many of them are patients have a slightly abnormal creatinine, they've been not feeling well, not drinking as well, and then as soon as they get admitted with a bit more fluids, they actually improve. So what can we say about the epidemiology? Well, it's more common and more severe in non-European ethnic groups here, but you can see in the African, American and Caribbean populations, it can be up to about 17 to 20 patients per total minimum. And what we can see in the epidemiology with children, there's limited data, but there's between 0.2 and 2 per 100,000 children are at risk of developing lupus per year. And the prevalence in some studies can be up to about 1 in 2,000, so a maximum of 50 per 100,000. So childhood onset systemic lupus erythematosus, or juvenile onset SLE, has a variable clinical manifestation with very unpredictable natural history. And what we know is through progressive clinical course that is seen in our children who can have a significant morbidity and mortality. And up to about 1 in 6 children with proven cases present in childhood with more severe organ involvement than adults. And why I'm interested as a nephrologist is because that renal disease is a major determinant of the long-term outcome, and it actually influences our management. We're using immunosuppressive agents. But both the hematological and renal disease are more severe in patients with childhood onset lupus compared to adult onset disease. Sorry, my light has just turned off, obviously trying to save electricity. We see a different spectrum in children, so cardiopulmonary involvement is rare, and cerebral lupus presentation is actually much more common. There's multi-system involvement with arthritis, autoimmune hepatitis, and a macrophage activation syndrome. But what we know in children is that they are slightly different. We worry about young adolescents with their growth, their education, their evolving identity. There's different aspects to their quality of life, and many of them can be worsened when we have the side effects that come with corticosteroids. So the adherence to treatment is really important. But if we compare almost any adult rheumatological condition with pediatric, then lupus is the one that probably has the same autoimmune process. We use the same classification criteria, we use the same disease markers and the same drugs, which I'll talk on a bit. So the next question is about lupus nephritis. So which International Society of Nephrology and the Renal Pathology Society class of lupus nephritis has subepithelial deposits? Is it A for class 1 lupus nephritis, B for class 2 lupus nephritis, C for class 3 lupus nephritis, D for class 4 lupus nephritis, or E class 5 lupus nephritis? So I'll just give you a few minutes. And are the scores in, Marina?
They're not yet. People are still voting. Oh, they're coming now. Okay. So 36% of our listeners said class 5 lupus nephritis. And then 24% went for class 4, 25% for class 3, 13% for class 2, and only 1% for class 1.
Okay, so I think it's the majority vote, the 36%, who said E, class 5 lupus nephritis. So I think as Professor Anders talked upon, the fact that children present as like adults with a myriad of symptoms. With proteinuria, we see those with nephrotic syndrome being more with the class 5 lupus nephritis, who can have the subepithelial deposits. We do see microscopic and rarely macroscopic, usually Coca-Cola colored urine, but also evidence of renal dysfunction and hypertension. But what we do know is it's very difficult to predict the histopathology just based on clinical and serological markers. So over the last almost 50 years, there's been various consensus meetings of pathologists together with clinicians looking at the classification, which was updated in 2003, which is the International Society of Nephrology and Renal Pathology Society Working Group. And their classification always seems like you go from class 1 to class 6 and increasing, but it is not quite like that. So we'll start with the class 1, which is very minimal changes, so minimum mesangial lupus nephritis, and very often, even if you've got a patient who doesn't have any of the features but may have a bit of tubular proteinuria, you may begin to see some minimal mesangial lupus nephritis. But when there starts being more proliferative lesions, it is more akin to class 2 lupus nephritis. Class 3 and class 4 is that escalation from class 1 to class 4. So class 3 is where you have a focal lupus nephritis, which involves less than 50% of the glomeruli. And you need to have at least 10 glomeruli in your biopsy really to comment. We then subclassify the focal lupus nephritis into those which show active proliferative lesions, which are denoted by an A, those that have chronic fibrosis, sclerosing lesions, which are documented by a C, and those that have both active and chronic lesions, which is ISNRPS, class 3A/C. Class 4 lupus nephritis is where you have a diffuse lupus nephritis. It involves more than 50% of all the glomeruli, and within that, you look at each individual glomerulus and you see whether less than 50% of each glomerulus is involved, in which case it would be segmental, and if it's 50% or more, it's a more global or class 4 global lupus nephritis. And again, class 4 is delineated active, chronic, or active and chronic. So that's the escalation from class 1 to class 4. Class 5 is it's a diffuse membranous lupus nephropathy. And class 5 in this classification was changed, whereby you could say that you had patients with both class 3 and class 5 features and class 4 and class 5 features. Class 6 lupus nephritis we don't really see, because that is when you have advanced sclerotic lupus nephritis involving more than 90% of the glomeruli. And these children would actually be on dialysis with very small kidneys, which, to be fair, would be very more at risk of bleeding from performing a biopsy, for which we would not proceed. So this is my take on the lupus nephritis histopathological. You can either have Endocapillary hypercellularity, which if less than 50% of the glomeruli is a class 3 or more than 50% of the glomeruli is a class 4. If you don't have evidence of endocapillary hypercellularity, it can either be a mesangial hypercellular class 2 lupus nephritis or a class 5. So Professor Anders touched on the aims of treatment. So what we really want to do is induce and maintain a remission. We want to choose agents that minimize toxicity and maximize effectiveness, and we want to reduce renal flares which are associated with worse prognosis. So this is some of the historical data from Stuart Cameron, who was an adult nephrologist who looked after adults and children south of London. And you can see here that before we had the advent of good immunosuppression with corticosteroids and the advent of azathioprine, that about 10% of children would have died from lupus nephritis within the first 5 years. So what therapies do we have? Well, we've touched on some of these. I think azathioprine does have a role, but we very often will use mycophenolate mofetil and rituximab. Historically, there's been intravenous cyclophosphamide, and there are other immunosuppression. So the first question is which ethnic groups respond better to mycophenolate mofetil than intravenous cyclophosphamide? So which ethnic groups respond better to mycophenolate mofetil rather than intravenous cyclophosphamide? Is it A, B, C? A is for Asian, B is for Black community, C is for Caucasian, D is Hispanic, and E, there's no racial or ethnic differences. So which groups respond better to MMF than IV cyclophosphamide? This feels a bit like the Eurovision Song Contest. Marina, can you give us the votes, please?
Yes, they've just come through. So 32% of listeners replied Caucasian, followed by no difference, 23%, Asian, 21%, Black, 16%, and Hispanic, 8%.
Okay, that's very, very interesting because actually it's the lowest groups, which is the truthful answer here. So it's actually B for Black and D Hispanic groups, which is actually very interesting. So there's a lot more that we need to understand about the pharmacogenomics involved in the metabolism of drugs, but I think also in the response. I have some patients who've almost failed all treatments in consideration of stem cell transplantation who've responded very well to azathioprine as well. But what this question is really about as well is the fact that most of the studies which started with MMF were actually about non-inferiority. And the reason being is because historically you would need to be admitted potentially even every month for your intravenous cyclophosphamide infusion. So this is one of the first studies, which is 20 years old now, but it was a randomized controlled study that was very well received in the New England Journal of Medicine by Chan et al., where patients were randomized to 1 gram twice a daily of MMF for 6 months of cyclophosphamide at 2.5 milligrams per kilogram per day. And it was one of the first studies which showed actually that patients did equally as well. What you can see here, though, is that there were 2 patients who died in the cyclophosphamide group. There were none in the MMF group, and there were more side effects with amenorrhea, hair loss, and leukopenia, and almost double the rate of infections. So the important thing is that if patients achieve remission, then they actually do very well. The renal and patient survival is 94–95%. And what much of the international data is beginning to show is that many children and young adults do not reach a complete renal remission. If you don't get a remission, then the renal survival can be as low as 1 in 2 at 5 years and 1 in 3 at 10 years. And the overall patient survival is reduced to about 70% at 5 years. And those who have a diffuse proliferative class 4 lupus nephritis generally do worse, especially those if they've got a reduced GFR, hypocomplementemia, and active lupus nephritis for a year. Whereas those who don't have a genetic form of lupus nephritis, where you normalize your complement C3/4 and you have a reduction in your proteinuria by 8 weeks, usually do much better. So where do we get some of the data? Well, one of the first was the open label study called ARMS of class 3 to 5 lupus nephritis, where patients either had 1.5 grams twice a day of MMF or intravenous cyclophosphamide up to 1 gram per meter squared per month, with corticosteroids at high dose at 60 milligrams, which was tapered. And this was one of the first studies which involved children, so adolescents between 12 and 18 were also included. And you can see that 370 patients were randomized into the MMF or cyclophosphamide group, and about 150 in each arm completed the first 6 months. And what you can see here is very similar outcomes between the two groups. However, as I said, Black and Hispanic responded more often to MMF than other races that were seen, and it worked equally well in adolescents and adults with a class 5 lupus nephritis. In this study, however, you can see that there was double the gastrointestinal side effect with diarrhea as well as death in 5%, but you saw a lot more nausea, vomiting, and alopecia in the cyclophosphamide group. Interestingly, of those patients who were in that study, the maintenance study, were either then randomized to receive MMF or azathioprine. And you can see here in the Kaplan-Meier graphs that the probability of being free of treatment failure was much better in the MMF group and much less renal flares, which is why MMF has become more of the mainstay of treatment, whereas, as you know, some of the vasculitis studies preferred azathioprine as the treatment. And if you look here comparing MMF versus azathioprine, you can see there's a tendency for MMF to be better. Some of them, the studies, do not cross the one line in this forest plot, but many of them actually do. The MAINTAIN study looked at patients with a proliferative lupus nephritis that were treated with steroids and 6 fortnightly intravenous cyclophosphamide, and patients who were either randomized to MMF and azathioprine. And although not statistically significant, there was less renal flare, about 1 in 5 in the MMF group. And again, this is the meta-analysis of cyclophosphamide versus MMF, and you can see here there was a favoring towards MMF, but many of them actually crossed the one line. So patients who have a difficult disease where it's very severe, they don't respond. Some patients that are non-adherent and those who don't come to clinic make us really want to think about using intravenous agents. And at our armamentarium, obviously, we can give steroids. I will talk a little bit about them later. But cyclophosphamide has always been of the favor. And when I started in pediatric nephrology, the ward was always full of patients coming in to get their infusions. However, rituximab and MMF has really changed, and that's become our mainstay of treatment in children and young adults with lupus nephritis. And I put here, we really use it in patients presenting as opposed to just those historically where we tried it in those with refractory diseases. Corticosteroids, which have formed the basis of all regimens, are really now beginning to be thought of that we should not be using as much. MMF is a good agent for both induction and for maintaining remission. And I think the previous gold standard, cyclophosphamide, although still used in many countries, has not got the formative play that it really did 10 and 20 years ago. Azathioprine is an effective drug for maintenance treatment of some children with lupus nephritis if they're otherwise doing well. So very often patients will be pulsed with methylprednisolone up to 600 milligrams per meter squared. MMF will be introduced and increased up to 600 to 1.2 grams per meter squared. And people really used to consider monthly cyclophosphamide as an alternative to MMF. But as I say, we would very often actually give rituximab together with MMF to get patients off methylprednisolone. So what is evidence-based practice? What do we know? Well, there's much in the literature, KDICO, and we've got the EULAR, ERE, DTA, we've got various consensus, the ACR. The KDICO, interestingly, if you remember, a level 1 is where you recommend, because most people in your situation would want that treatment. And we have supporting evidence where A is high to D very low. And you can see here that we recommend initial therapy with corticosteroids, combination with either cyclophosphamide or MMF in the adult KDICO guidelines. And we recommend after initial therapy, patients receiving azathioprine or MMF. And when we look at the recommendations for children, what percentage of pediatric lupus recommendation are based on the lowest quality of evidence or complete lack of evidence? So very often it's when we actually have consensus. So if you want to start the poll again, So what percentage of pediatric lupus recommendations are based on very low quality of evidence or lack of evidence? Is it 10%, 20%, 30%, 60%, or 90%? So what percentage of pediatric lupus are based on very low quality of evidence or lack of evidence? So in other words, it very often becomes a consensus around the table. How's the poll, Marina?
Okay, it's just arrived, and it says, so 39% of listeners replied 60%, followed by 31%, 90%, so people were very pessimistic, and then down 20% of listeners replied 30%, and then 5 replied 20%, and the other 5 replied 10%.
Okay, thank you very much, Marina. For this question, I'll keep you all guessing a little bit longer. It is a very interesting question, and I think we need to do more randomized control trials, which is what we are trying to do at the moment. So very interesting results. So let me talk about what happened with our discussions of pediatric lupus nephritis. We suggest that children with lupus nephritis receive the same therapies with dosing based on patient size. And the EULAR-EDTA recommendations, which we initially published in 2012, we said compared to adult onset disease, lupus nephritis is more severe. There's increased damage accrual, there's more common at presentation, but the diagnosis, management and monitoring is very similar to that of adults. And of course, we need to think about a transition program to adult specialists. And we had almost consensus with 9.6 out of 10 being the mean score and the median of 10. But when we look at the evidence, the answer now that you can see here is it was 60%, is that the 2D grading was 50% and there was 13% that were non-graded. So there's a lot more work to do within the field of pediatric lupus nephritis. We updated our recommendations in 2019, which have just been published, and we basically said that really nothing much had changed when it came to the decisions about children. We also have information from the Cochrane collaboration, and I think their treatment of saying steroids initially trying to wean with cyclophosphamide or MMF, a maintenance continuing with some steroids with MMF or azathioprine. You can switch induction therapy if there's no response. Personally, I would consider using for 3 and 4 lupus nephritis MMF together with cyclophosphamide and getting MMF together with rituximab and getting them off steroids as quickly as you can. And then if there's no response, and considering, for example, could you use a calcineurin inhibitor if there was a class 5 lupus nephritis? As Professor Anders said, we need hydroxychloroquine, we need to treat hypertension, proteinuria, hyperlipidemia, we need to give aspirin if there's antiphospholipid antibodies or anticardiolipin antibodies, we need to anticoagulate, especially if they're nephrotic, and we need to use non-live vaccines and treat vitamin D deficiency. We also will use immunoglobulin for those with severe non-responding disease, plasma exchange, infliximab, and sometimes stem cell transplantation. And here's some of the initial data which came out over a decade ago showing that potentially using cyclosporin in patients with membranous lupus nephritis was actually had a mainstay in some of our patient groups. However, interestingly, the adult recommendations are that if you've got 3 and 4 class lupus nephritis, you treat that way. But if you've got a class 5 with proteinuria, giving ACE inhibitors and angiotensin receptor blockers and managing hypertension, and only giving corticosteroids or further immunosuppression if you have more proteinuria, whereas I think in children we would be giving immunosuppression much earlier on. I just wanted to touch on a little bit of the rituximab data, which we historically gave to children and young people who had multi-systemic life organ-threatening disease, although with very active disease. And we published the first series of 7 patients where we showed good outcomes with no adverse effects and good disease control. The Canadian and French group published the next series of 11 patients where they had a lot more adverse effects, but they were doing more hematological monitoring, even checking full blood count in between the 2 doses, a fortnight apart of intravenous rituximab. We then went on to publish 21 treatment episodes in 19 children aged a median of 14.5 years. Most were female. They had lupus for between 1 month to 9 years, with a median of 3 years, that were followed up for at least 6 months. And you can see here 4 in 5 children had lupus nephritis. They had a myriad of other treatments along the way, and we showed that their disease activity improved with reduction in BILAG, an improvement in the renal function with their eGFR and albumin increasing, and a reduction in the degree of albuminuria. There was improved immunological response with a reduction in ANA and double-stranded DNA antibodies, and improvement in complements C3 and C4, with an improvement in hematological parameters, with a reduction in ESR, and improvement in the hemoglobin, lymphocytes, and platelet counts. What we showed is that most children showed evidence of peripheral B-cell depletion, and I think it's what happens within the kidney which is also important. Patients had clinically significant improvement in the symptoms and signs, and there were some anecdotal responses that the patients had never felt so good, although 1 in 4 developed a zoster reaction, which we have seen, and also children with shingles. We then went on to do a dual center study, where again we showed in a group of 63 children, young people, they had the same improvements that I've described. But this has led us to be concerned about the side effects of corticosteroids, the new selfie generation who want to look good. And let's face it, the side effects of corticosteroids do worry our young adults. This is one patient that I had who's almost 16 at this time. She's now been transferred to adults. She had pulmonary hypertension with sickle cell anemia, but actually did very well on rituximab infusions regularly as well to minimize her cyclophosphamide exposure. And this was another girl who's just messaged me, who's in her 20s now, just finished college, and she had lupus since the age of 9, presenting with a thrombotic thrombocytopenic purpura requiring methylprednisolone and plasma exchange, who's done very well again with rituximab. And she responded very well to azathioprine. We've gone on to do the Rituxiloop trial, where we're actually using rituximab with minimum corticosteroids, and this was in 18 adults and 4 pediatric centers, trying to show that you don't need as much steroids as you previously thought. There are other neurobiological agents that we are around the corner. We don't have time to go into them today, and stem cell transplant has been used in a minority of patients because actually the therapeutic associated morbidity and mortality is quite high. So in summary, lupus is a multi-system disease, a different spectrum from adults, but involves various subspecialties and has an unpredictable course. We need to assess both the disease activity and damage with quality of life assessments. Rituximab has a role previously in refractory disease, but now in treating active disease. And we also need to collaborate with our adult colleagues and think about the long-term outcomes. MMF has taken the role of cyclophosphamide and azathioprine. Rituximab is effective but not proven in randomized controlled trials, which I didn't have time to go into today. And belimumab is now being registered for the use in lupus and lupus nephritis. And this was a quotation from a patient who's an adult who wrote about lupus. And in this article, you can read that she actually had undiagnosed lupus as a child, and it was diagnosed as growing pains within her pediatric span, but it was only an adult when she said, without it, I would not have learned so much about myself and about life in general. With support from friends, family, and clinicians, dancing with the wolf is not all doom and gloom. I've just left here some data that you can see that is published, including our involvement in the SHARE initiative for both lupus nephritis and lupus itself. And I wanted to finish by saying nothing that's worthwhile is ever easy. And the next webinars are coming up here are the ones for ERKNAT, but at the 53rd ESPN annual meeting 2021, I will be talking about newer treatments which are coming up for children and young people with lupus nephritis. Many thanks for coming today to the webinar and for listening to me, and I'm very happy to answer questions.
Thank you, Steve. That was really great and very complete. We're running really short of time. There is one question that I wanted to make because it was asked by Dr. Graham Smith, even for Professor Anders, but it wasn't, we didn't have time for it. So the question is about the use of ACE inhibitors in the treatment of lupus nephritis.
Yeah, it's a very interesting question, and I've been involved in some of the newer studies which are opening up within children and young adults, and it's a really difficult area, because my personal view is if your renal function is not that bad, ideally, actually, I would start ACE inhibitors pretty quickly. And one of the issues is in studies is that they want to use the proteinuria or albuminuria as a way of monitoring how effective newer agents are in the treatment of lupus nephritis. So therefore, they don't like any change in ACE inhibitors, and they don't like the addition of ACE inhibitors. So if you're going to be starting patients on treatment, it's actually quite nice to get a low level of ACE inhibition in quite early on, and then you can see what modulates. Because obviously, when you have proteinuria, we don't know whether it's from active disease, apart from looking at our markers to see if the patient's got active disease, or whether actually you're seeing proteinuria because it's a chronic damage which has happened to the kidneys. So I'm very much in favor of using ACE inhibitors and using them early on with their either initial presentation or with their presentation of lupus nephritis.
Thank you so much, Steve. So at this point, I think we're slightly over time. So I'm going to ask you, as well as we had asked Joachim Anders, if you're happy to take questions by email for the people that still have them. And I'd like to thank everybody for participating. This was a highly successful and very well attended webinar with two absolutely spectacular speakers. Thank you so much to you both, and thank you to everyone for participating. And you can see here what the next webinars will be, and good afternoon to you all.
Thank you very much, and goodbye to everybody, and thank you for joining us.